Mick.
Thank you, Professor Ines Shaltut and Organizing Committee for inviting me to take part in this Congress. It is a great pleasure to celebrate 100 years of insulin discovery and the many lives this has saved, and also the many lives that will be saved in the future. The talk is going to be split into these subtopics. Why chronic kidney disease in diabetes, i.e. diabetes kidney disease, is important. The epidemiology will tell us that. We'll again just remind everyone the definition of diabetic kidney disease, the pathophysiology, and then we'll focus particularly on the therapeutic interventions for primary, secondary prevention in the development progression of diabetic kidney disease. And of course, we have to discuss in the at the end of the talk whether this is all optimism or whether this is all gloom. The epidemiology is well known to everyone, and it always worries everybody when we actually talk through it. Not surprisingly, there are 422 million people with diabetes worldwide. 55 million of those are in the MENA region, and of course 8.8 million out of a population of 58 are in Egypt. And the prevalence, more recently, Khalil and colleagues has published a review in 2019 when they sampled 506 subjects with type 2 diabetes in Alexandria and found a prevalence rate of 33.2% had diabetic kidney disease. Worldwide is the cause of death in 21% of type 1 diabetes and 11% of type 2 diabetes. The definition is very clear now, and is the presence of proteinuria of more than 30 milligrams per gram and or a drop in renal function, eGFR, below 60 mils per minute. But of course, we have to exclude other causes of kidney disease before we make this clinical diagnosis. And one of the common causes of proteinuria is urinary tract infection, and it's important that we've excluded that before we make that diagnosis. Overall, about 40% of people with diabetes will be affected with diabetic kidney disease. The Kidney Disease Improvement Global Outcomes came up with a more precise description of chronic kidney disease in patients. And they have suggested this is defined as abnormalities of kidney structure and function present for at least 3 months. And it's the classification is according to level of glomerular filtration rate as calculated from the formula that the labs will give us, coming from a level of 90 mils per minute of eGFR is classified as G1, i.e. normal or high, and then level of 50 mils per minute or less is end-stage kidney disease, G5, and these patients will be considered for renal replacement therapy, either with dialysis or transplantation. And those that are not suitable for those therapies, then obviously they'll be considered for just conservative management. And in between, mild to moderate to severe, again, according to the level of GFR as it's dropping. But more importantly, we also have to look at how much protein is in the urine for these patients. And this is therefore classified as A1 to A3, A1 being normal, less than 30 milligrams per gram, and A3 being more severe, more than 300 milligrams per gram. So those patients in the green area have a better prognosis compared to those in the red area, i.e. those in the red area will tend to progress towards end-stage kidney disease more quickly, and it is important that we identify these patients and treat their risk factors as aggressively as we can. So this is a slide just showing the relationship to the presence of proteinuria and eGFR over time. As you can see, if you diagnose diabetes early, then there won't be any proteinuria at all. The earlier you diagnose diabetes, and over time, as the glycemic control is poor and these patients develop chronic kidney disease, you can see actually that their proteinuria increases over time. And by the time it's up here, then the eGFR, i.e. the renal function, is also dropped over time. But by the time the patient is having microalbuminuria, actually the eGFR in most of them is within the normal range. But the time the proteinuria is now very evident, i.e. clinical nephropathy is set in, then you can see actually that the eGFR will drop rapidly. But this process takes between 10 and 20 years. So what are the strategies to prevent this going on? And one is to raise awareness amongst patients and staff. And I think this can be done through structured education. And there are several programs that we are aware of in the UK, and I'll share those with you later on. But the first thing is to implement lifestyle modification and treat risk factors to target. Now we know that lowering glucose is of benefit, and this has been shown in the all trials, the UK PDS and the DCC. But when we try to repeat these trials with a more intensive reduction of glucose to near normal, then some of these patients actually came to harm. And you remember the Accord trial. In fact, patients in the intervention group, there was more problems with that group of patients compared to usual care. So no wonder when the FDA put a mandated that all new products, they should be evidence that they are not anymore inferior to the old agents. Particularly also, they must show that they have cardiovascular benefit. And this has been shown in previous presentations, the relationship between good control diabetes and cardiovascular events. And you can see here a drop of HbA1c 1% in the DCC trial translated into risk reduction of 43% for cardiovascular events. And equally, for a drop of 1% in the UK PDS, there was a 37% reduction in cardiovascular events. But most of these events were actually to do with microvascular rather than macrovascular events, as you recall. And this is just a meta-analysis of all the newer trials that were done post DCCT and post UK PDS, showing that in fact, when you look at cardiovascular events, clinical events, the benefit was very small, although we tried to get the glycemic control towards 6.5. And you can see actually quite a lot of harm came to those patients that had intensive glucose treatment. So since then, we've seen quite a large publication of studies to do with the SGLT2 inhibitors here, GLP-1 antagonists here, DPP-4 and PPAR agonists here. And we haven't got time to go through all these trials, but if I can show you this slide, which is a meta-analysis of all of them, and you can see there's benefit ranging from those trials that looked at diabetes patients with CKD of, I beg your pardon, CKD stages 1 to 2, and this group stages 3 to 5, and then Credence more recently they studied the patients in all stages of CKD, and you can see here significant benefit in cardiovascular events as well as renal outcomes. Similarly, these are 7 trials that were published with a GLP-1 receptor antagonist, and you can see that there was a risk reduction for all-cause mortality, hospitalization due to heart failure, and renal outcomes and progression in patients with chronic kidney disease. So this is where these drugs are working on the glomerulus, and you can see here, this is a glomerulus, the afferent arteriole and the efferent arteriole. And just to remind you, glomerular filtration rate depends on the gradient between these two areas. So the efferent arteriole usually has a higher tone compared to the afferent arteriole. So the ACE inhibitors, if this tone is much higher than it should be, then the ACE inhibitors will tend to reduce that tone by blocking angiotensin II. And therefore, that will lead to preservation of renal function through the reduction of interglomerular pressure. The SGLT2 inhibitors work on the arteriole by causing dilatation of arteriole to maintain or reduce interglomerular pressure. In both groups of agents, you'll see, first of all, an increase a decrease in the eGFR in both groups, and eventually that stabilizes and that causes a reduction in proteinuria and therefore confers renal protection. So the approach really, as you can see from what I've said already, 1 is to treat the target, 2 is to block the renin-angiotensin-aldosterone system, and 3 to select glucose-lowering agents with proven cardiovascular or renal benefit. So how do we do lifestyle modification? It is important to put these patients through structural education. There's a Daphne program in type 1 diabetes and the Desmond and Expert programs for these patients in the UK, and I'm sure there are other programs in other countries I'm not aware of. The benefit from RAS inhibition has already been shown very well, both for angiotensin II receptor antagonists. In this Ranal trials, losartan, showing a 43.5% reduction in risk in terms of doubling the serum creatinine, reaching end-stage kidney disease or death. Similarly with irbesartan, and of course the S inhibitors earlier on, ranging from 6.5 risk reduction for nephropathy in the microHOP study, and captopril in the captopril trial in 1993 of 12.1%, and the ramipril of 23.1% risk reduction. Now, if we take the multifactorial, we can see that actually the benefit is much better. So this is a study that's been published in 2021, and that was to evaluate the multifactorial intervention on the onset and progression of diabetic kidney disease in type 2 diabetes. Their target was to get HbA1c below 6.2, blood pressure 120 over 75 or less, cholesterol 80 milligrams per deciliter or less, compared to conventional therapy, i.e. usual therapy of 6.9% HbA1c or less, blood pressure 130 over 80, and cholesterol 120 milligrams per deciliter. There's 2,540 patients randomized into the 2 groups, followed up for to be followed up for 8.5 years. A total of 438 kidney events occurred. There were 181 in the intensive therapy group and 257 in the conventional group, showing that the intensive therapy, there was an association of significant reduction of 32% in kidney events compared to conventional therapy. And this is just a cartoon to show you how the study was conducted, but the conclusion is already been mentioned here. And this is just a graph to show you the separation of the two groups. So intensive therapy showing a significant benefit compared to conventional therapy. A similar study, actually, recall, was published as far back as 2003, where they split the 80 patients in the intensive group and 80 patients in the conventional group. They followed up the patients over 8 years, and you can see a 50% reduction in cardiovascular mortality, 60% reduction in progression of chronic kidney disease. And of course, there were some benefits in other areas as well. There was a 60% reduction in risk for retinopathy. This is just another way to look at it. You can see here a risk reduction for nephropathy significantly here, and retinopathy as mentioned, but also autonomic neuropathy. There was some reduction in progression of autonomic neuropathy. Not so well in sorting out peripheral neuropathy. So when they analyzed the STENO trial to see what actually contributed the most in the reduction of risk factors, so pretty much a lot of patients achieved to target lipid reduction, and they worked it out that there was a 73% contribution in risk reduction by getting lipids to normal levels, 13% for HbA1c, 11% for systolic blood pressure, and 3% for smoking. But overall, as a package of addressing multiple risk factors, there was a significant reduction in events by this approach. This is just showing that actually patients with chronic kidney disease or end-stage kidney disease would also benefit from statins if their cholesterol levels are high. So what about the guidelines? What do they say? So firstly, you are aware of this one, that if patients have atherosclerosis or at risk of cardiovascular disease, then they should be offered SGLT2 or GLP-1 receptor antagonists, either as monotherapy or as adjuvant to metformin, if metformin is not sufficient to get the glycemic control to satisfactory levels. And these are just the trials where this is all come from. And again, we haven't got time to go through them in detail. These are the KDIGO clinical guidelines for patients with CKD. And just to summarize, again, lifestyle modification is important. And first line is metformin. If eGFR is less than 45, then reduce the dose. If eGFR less than 30, these patients should not go on metformin, nor should those patients on dialysis. SGLT2 inhibitors, less than 30 mil, eGFR less than 30 mils per minute should not be offered, and the same thing with patients on dialysis. If metformin is not achieving glycemic control that is needed to target, then the preference is to add GLP-1 receptor antagonist as a second-line agent. So what other things we can offer our patients? And this is a study showing the effect of adding mineralocorticoid receptor inhibitor to the progression of chronic kidney disease that was published in December 2020 in the New England Journal of Medicine. And they enrolled and randomized 5,734 patients into placebo or 10 or 20 milligrams once a day of finerenone, a mineralocorticoid receptor blocker. Followed up the patients over 2 to 2.6 years and looked at the primary composite endpoint, a decrease of GFR of more than 40% or renal death, and cardiovascular composite of cardiovascular death, non-fatal myocardial infarction, stroke, or hospitalization due to heart failure. The patients were well matched in terms of patients' characteristics for age, sex, duration of diabetes, HbA1c, body mass index, and blood pressure. And of course, they also had to match the patients' groups for comorbidities, complications of diabetes, hypertension, hyperlipidemia, obesity, and presence of cardiovascular disease. And you can see here, in terms of follow-up outcomes, there was a significant benefit in the addition of finerenone, and you can see the graph separating round about 18 months of therapy. When they looked at the actual figures, there was a primary outcome event occurred in 17.8% of the intervention group compared to 21.1% of the placebo group, and the number needed to treat was only 29. So I suspect this agent or this group of agents are going to creep up in the guidelines pretty soon. So is this optimism? I am optimistic that now we've got so many tools to offer to our patients. One, to control glycemia. Two, to reduce complications. Three, to reduce progression of complications. And this is World Diabetes Day suggestion to raise awareness in the community for today. Everybody must paint their nails blue and wave to everybody and tell them all about the importance of diabetes prevention and good control of diabetes, and of course to celebrate 100 years of insulin therapy. There are other campaigns already that we've seen. World Kidney Day is the second Thursday in March, and that started in 2005. World Hypertension Day is 17th of March, again, that started 2005. And of course, on the 14th of November, since 1991, we celebrate World Diabetes Day. So I'm optimistic, and this is one reason why I just wanted to share with you. So these are the prevalence of end-stage kidney disease since 2002 to 2015. And you can see here that there are countries at the bottom here that have already plateaued and have reduced the prevalence of end-stage kidney disease. And then if you look at the ones that were not doing so well in Mexico, you can see that actually their numbers are also beginning to plateau. And you can see in America, the picture is quite similar, again, plateauing. And I hope that this will be the same over time in these other areas. So I am optimistic that we can achieve more in the future because of the multifactorial, multidisciplinary approach that I'm advocating. So in conclusion, diabetes is the most common cause of end-stage kidney disease. It's a high-risk factor for cardiovascular disease and premature death. Tight glycemic and cardiovascular risk factor control significantly reduces the development and progression of diabetic kidney disease. Lifestyle modification and careful selection of pharmacological agents of proven record to reduce the risk is key to preserve renal function for the future. Many thanks for your attention. Thank you.
Now for questions.
Thank you very much, Dr. Mike. I'm Professor Shireen Abdelghaffar. I'm Professor of Pediatric Diabetes, Cairo University. It's a very elegant lecture, actually, and while following your presentation, I want to ask you about your experience about type 2 diabetes commencing in childhood and adolescence and the progression of kidney disease. Is it more aggressive from your experience? because we now see type 2 diabetes since the age of 6 years, not only around adolescence. So do you think if we start the education and all the metabolic control, we can decrease the progression of chronic kidney disease through adulthood? Or as we see that sometimes complications are more aggressive in type 2 diabetes in children comparing to type 2 diabetes starting in adulthood? So I'm looking forward to know your experience about that. Thank you.
Yes, thank you for that question. It's very important to monitor children as well. So we recommend that those children that have had diabetes for 5 years or more should have annual screening for micro and renal function. I agree that you know, the risk will apply to them as well. Of type 1 diabetes that develop nephropathy, and they rapidly deteriorate over time. And there is some thought that this may be genetic related. So yes, I think the risk is there at any age. The important thing is early diagnosis and then early treatment with renin-angiotensin system inhibitors or blockers, treating cholesterol to target and so on. So yes, very important question.
Professor Mick, thank you for your elegant presentation. I am Major General Professor Abdel Khaliq Hamid, Military Medical Academy. I want to ask about the chronic kidney disease in diabetics associated with non-alcoholic fatty liver disease.
Yes, it is. This is a major problem for type 2 for liver disease as well. In terms of progression, I'm not aware that if you prevent non-alcoholic liver disease, whether the progression is reduced. But I know that if you have non-alcoholic liver disease, then the progression of chronic kidney disease is faster. Will coexist in the same patient, in particular hypertension as a contributor to progression of chronic kidney disease.
Thank you, Professor Mick, and I hope to meet you again.